Welcome to this explainer. Look, we're skipping the low-yield introductions today and jumping directly into a high-density clinical review. We are strictly targeting intricate anatomical pathophysiology and those discrete management traps that catch people off guard. If you're aiming for that elite 270-plus score level, you have to master these exact thresholds. We're going to consistently detail the specific mechanisms, the strict management mandates, and the key diagnostic markers that routinely trap even highly seasoned clinicians. Let's get to it. We're bypassing the basics and starting directly with the absolute pathogenic driver of malignant otitis externa, the Pseudomonas invasion. Now, this is not just some stubborn ear infection, okay? This is a highly aggressive osteomyelitis of the skull base. When you evaluate an elderly patient, specifically one with poorly controlled diabetes or systemic immunosuppression, your index of suspicion has to be immediately elevated. The metabolic environment in these patients allows Pseudomonas aeruginosa to rapidly invade right past the soft tissue and directly attack the temporal bone. So what's the strict diagnostic threshold here? It isn't just mild discomfort. You're looking for excruciating, relentless ear pain that is characteristically way worse at night, and that's usually accompanied by purulent otorrhea. When you actually look in the ear, otoscopy strictly reveals granulation tissue right at the bony cartilaginous junction of the external auditory canal. And as this osteomyelitis relentlessly destroys the temporal bone, it begins to threaten adjacent structures. The most critical immediate threat here is to cranial nerve 7, which clinically presents as an ipsilateral facial droop.
Now, this brings us to a massive management trap. The pharmacologic mandate here is absolute. Topical agents are entirely, absolutely, insufficient for osteomyelitis. Listen, do not fall for the topical therapy trap. Management strictly requires prolonged systemic anti-pseudomonal therapy to halt the progression of this skull-base destruction. Classically, this means you are initiating intravenous ciprofloxacin. You have to aggressively target this specific organism systemically.
Let's test this in practice. We have a 72-year-old diabetic male presenting with severe right ear pain. His tympanic membrane is intact, but he has distinct granulation tissue in the floor of the canal and a noticeable right-sided facial droop. Your task as the clinician is to explicitly select the appropriate intervention targeting this precise anatomical spread.
Let's exhaustively dismantle these traps. Option A, topical fluoroquinolones, that's designed for uncomplicated external otitis, absolutely not for bone involvement. Option B, amoxicillin, clavulanate, completely lacks the strict anti-pseudomonal coverage required here. Option D, mastoidectomy, that is reserved for highly refractory surgical cases, never initial management. And option E, topical corticosteroids, will actively exacerbate the underlying infection. So the precise anatomical spread and the definitive presence of granulation tissue dictate option C, intravenous ciprofloxacin, as the absolute mandate.
This comparison strictly isolates the anatomical and metabolic variables that definitively separate a simple infection from a life-threatening osteomyelitis. Both feature ear pain, right? And both can even involve Pseudomonas. But uncomplicated otitis externa merely features a swollen erythematous canal with no granulation tissue and responds perfectly to topical drops. Malignant otitis externa, on the other hand, features that hallmark granulation tissue, extreme nocturnal pain, impending cranial neuropathies, and it strictly mandates that systemic IV therapy.
Module 2, Cavernous Sinus Thrombosis and Oculomotor Traps.
Observe the precise hemodynamic sequence here. Pathogens don't just magically appear in the cranial vault. An infection, often just a simple staphylococcal furuncle or sphenoid sinusitis, begins in the facial danger triangle. Because the facial venous system is completely valveless, there is literally nothing stopping retrograde spread. So the uncontrolled facial infection travels backward, perfectly localizing into the cavernous sinus and initiates a catastrophic septic thrombosis.
Now, the cavernous sinus is a dangerously packed space. It houses cranial nerves 3, 4, 5-1, 5-2, and V6 alongside the internal carotid artery. But cranial nerve V6, the abducens nerve, is uniquely vulnerable. While all the other nerves are safely embedded in the lateral wall of the sinus, CNV6 floats freely right through the center. Consequently, as that septic thrombosis expands and the pressure rises, CNV6 is strictly the first to fail. This completely paralyzes the lateral rectus muscle, driving a strict lateral gaze palsy. The systemic hallmarks rapidly follow: abrupt fever, severe headache, and rapidly progressive bilateral periorbital edema.
Let's apply this to a rigorous clinical evaluation. A patient presents with a high fever, sudden bilateral eyelid swelling, and the absolute inability to abduct their right eye. and this whole presentation followed a seemingly benign squeezed pimple on their upper lip. You need to identify the precise anatomical structure that fails first in the specific pathophysiology. Exhaustively evaluating this diagnostic matrix. Option A, the optic nerve, is a classic trap. It isn't even in the cavernous sinus. Options B and C, cranial nerves 3 and 4, are in the sinus, sure, but they're protected in the lateral wall and fail much later. Option E, cranial nerve 7, controls facial expression, not extraocular movement. So it's option D. The free-floating central position of the abducens nerve, CN6, is what makes it highly susceptible to early compressive failure. To avoid a catastrophic misdiagnosis, we must strictly separate orbital cellulitis from cavernous sinus thrombosis. Both of these can feature periorbital edema and ophthalmoplegia. However, orbital cellulitis remains strictly unilateral and localized entirely to the orbit. Cavernous sinus thrombosis might start unilaterally, but it rapidly crosses the midline via intercavernous venous connections, threatening both eyes and driving severe cranial neuropathies that are completely out of proportion to the external orbital findings.
Moving on to Module 3, Subclavian Steele Syndrome and Hemodynamic Rerouting.
We are looking at a pure mechanical divergence here. The pathophysiology strictly requires a severe atherosclerotic stenosis in the subclavian artery that is located proximal to the origin of the vertebral artery. When the patient exerts that ipsilateral arm, the distal vessels actively dilate to meet the new metabolic demand, but because the proximal blockage prevents normal forward flow, basic physics takes over. Blood is strictly siphoned backward, flowing retrograde down the ipsilateral vertebral artery, literally stealing perfusion away from the brainstem just to feed the exercising arm.
The resulting clinical triad inexorably links two seemingly completely separate vascular territories. You have arm ischemia, pain, fatigue upon exertion, and significantly unequal radial pulses, but concurrently, you also have vertebral basilar insufficiency, syncope, intense vertigo, or diplopia. The absolute key to nailing this diagnosis is the hemodynamic trigger. The severe neurologic symptoms occur strictly during physical exertion of that affected limb.
Consider how this presents in real practice. A 68-year-old male experiences intense vertigo and left arm fatigue entirely and strictly when he uses his left arm to paint the ceiling. On physical exam, his left radial pulse is markedly diminished. What is the precise pathophysiologic driver of this presentation? Let's look at the options.
Option A, a distal blockage, is a mechanical impossibility. It would never reverse vertebral flow. Option C, a vertebral thrombosis, would cause constant ischemia, not an exertion-linked trigger. Option D, Takayasu arteritis, is a huge trap. It's demographically incorrect for an older male without systemic inflammation. And option E, a coarctation, would affect the lower extremities symmetrically. Therefore, option B, a proximal subclavian stenosis, is strictly the correct driver. It drops the distal pressure gradient and forces the vertebral arteries to siphon blood backward.
This perfectly highlights our final clinical divergence. Both Takayasu arteritis and subclavian Steele syndrome can present with unequal upper extremity pulses. But the systemic inflammation of Takayasu, characterized by a high ESR in young Asian females, sharply contrasts with the purely mechanical, exertion-driven atherosclerosis of subclavian Steele in older male patients.
As we wrap up this explainer, I really want you to think about how these microscopic structural changes create massive, devastating systemic failures. How does the lack of a single venous valve in the face, or just a millimeter of proximal atherosclerotic plaque in the subclavian, systematically dismantle entire neurological networks? Mastering these singular anatomic thresholds will absolutely transform your diagnostic accuracy. The next time you see a seemingly simple symptom, ask yourself what hidden microscopic trap is actually driving this failure. Keep isolating these variables, and I will see you in the next explainer.